Can I place this implant in a prosthetic position? So first we're looking at to see if we have the bone to place it, to visualize it, CT scan perhaps. Now we want to see, could I place this implant in a proper prosthetic position? And of course, in order to get any implant that's placed, you have to have good primary stability. Must. If that implant is not stable, it's going to fail. So if you place the implant and you're putting on your healing abutment or cover screw, and when you're screwing in the cover screw, if you see your implant turning, that's not good. With your fingers, you're able to put about 15 to 20 newtons of force. If you go at it pretty hard, about 20 newtons. So if your implant is moving when you're screwing in your cover screw, that means that you don't have 15 or 20 newtons of stability. Most probably that implant's going to fail. It could still integrate, but you don't want to stop at that point. You want to take out the implant and go with a slightly larger implant. And then another thing to keep in mind is, do I have enough native bone? Okay, so do I have bone apical to my socket? Because we always want to place a few millimeters apical, because that bone is much stronger. Okay. So this is a really good picture, because when first implants were being placed immediately, people were going right into the socket. So you take out the tooth and people were going right here, right through here. Okay. Now, it's been shown you have to place it more palatal, engage more of your native bone, and at the same time, if you follow your bone, because the maxilla always has an angle. It's never straight up and down. And if you go following this, you're going to come out of the facial. Okay, so you have to be very careful. Not at the same time you want to go more palatal, you have to make sure you come out of the cingulum. Because if you come out of the facial, then you're going to have very short distance to the tissue. And you know, when you see a patient that has a very gray line around their implant, that's because of that. That could be avoided all the time. By placing your implant more palatally, at an angle where the implant is coming out of the cingulum, placing the implant deeper, soft tissue grafting, bone grafting, all of these things can prevent that. You could hide it with an abutment, with a zirconia abutment. So we always start with a round burr or a lance drill, which is very sharp. And that's a little bit better, actually. If you have something that's sharper, when you're on this slope, you're not going to slip. So once you get in a little bit, then you can go in with your 2mm twist drill, a little bit deeper, and then 3.5mm, place your implant. Which size implant do we want to place? Do we like wide implants or do we like thin implants here? Do we want to cover this entire socket with an implant? No. Again, we want to have a buffer. We don't want the implant to be in this area. We want it to come out of this area. We want to be about the 4 to 4.5mm range. Okay, 3.7 to 4.5mm range. Okay, too thin, and you can't get enough stability, perhaps. Lengthwise, you want to be as long as possible. You don't want to hit the floor of the nose. Okay, and you don't want to come out. A lot of times I've seen people place their implant and it comes out of here. And the patient always feels something. They come back and they say, and you won't even know because you've never seen this area, but sometimes they come out poking out a little bit here. So always make sure you're a little bit more palatal, you're in the bone, and if it's very sloped, to make sure you don't come out of that buckle. So we want to always be leaning our drill against the palatal wall. Okay, never against the buckle. The buckle's thin, and any kind of pressure on it could cause the whole thing to just crack or come off. Okay, but in general, when in doubt, basically you always want to place your implant deeper and more palatally. when in doubt. Something I do, with these cases is I always like to charge just a little bit more on anterior cases to give yourself room for custom abutment. Okay, because you just never know. In fact, some offices automatically every anterior case is a custom abutment, sometimes custom zirconia abutment. And I think that is the right thing to do, just to give yourself a little bit of cushion, because you don't ever want to, once the implant is integrated, you don't want to get back in there, especially if it's cement retained. These days we're seeing more and more cement retained, and also keep in mind when you cement these, you have to get around and really clean out your cement if there's any cement left over. Because I get in there afterwards, and whenever I see bone loss around implants, I would say 80% of the time it's a little bit of cement that got underneath. Once I remove it, then the bone loss stops. Okay, so you can see this is more leaning on the palatal. The buccal bone you can see a little bit. It's not as much right now focused, but you can see it's intact there. All right, so in this case we have a stent. You don't always need a stent, especially if you're placing an implant. It's got to be right down the middle. So place it, start your drilling right in the middle. Something I always like to do is take a mirror right after you do your first drill, put a pilot drill or leave your drill in there, take your mirror and look through your mirror, and you'll see the angulation better. Something about looking at your mirror. When you create a prep and you look in the mirror, you can see it better. Same thing here. Get your mirror, you'll see the angulation a little bit better. We want to always make sure it's coming out of the cingulum. Why out of the cingulum? Because also it gives us more room for thickness of porcelain, so that it doesn't show as much grayness, or you can get the right color. Now, we have a gap here. Always we're going to have a little gap. Okay? When you have a gap, the best thing to do is pack it with some bone, because you don't want this tissue to come underneath and to fill in. Also, filling up this gap will help preserve that bone and also the tissue. You don't get as much recession. And if it was up to me, because sometimes the patient will dictate, if it's up to me, I always like to have like a healing abutment or temporary on top of this. Why? Because it holds your tissue and it holds the papilla. When you get primary closure, everything collapses, so you lose the papilla. Okay, and then you'll see most of the cases, patients, if you have a healing abutment and then you have a flipper, it doesn't always work out. There's always a gap. People always see the metal, and it's 3 months that they have to wait. So what we do is, in those situations, we bury it, come back and uncover it. So at least it's only a few weeks that they have to have the healing abutment with their flipper. Or if you have a Maryland bridge, or if you have a bridge, then you don't want to necessarily put a healing abutment. Now, these are 3 scenarios when you take out a tooth and place it. When you take out a tooth, this is the ideal one, because you have a defect, and whenever you have a defect, this is where the bone is going to come, and the blood supply is. So you can grow bone in holes, okay? But you cannot grow this bone taller. Just like I can't be taller, I wish I could, but I can't be taller. This bone cannot be over here, okay? But you can fill in holes. Why? Because it's all about the blood supply, okay? Where you have blood is where you have the growth, the nutrients, the food for the bone. So there's some studies that show that you don't even, if your gap is smaller than 1.5 millimeters or about that size, you may not even need to place bone graft. Just to let you know what's out there. But I like to place my bone in there just for reassurance and make sure that it holds the tissue better. Okay, so basically you can see these are the ones that you really don't want to place the implant. This is ideal.